Now, when we go on to talk about the Truncus Arteriosus, what I want to do is just talk about, what happens normally. Is it normal to have a Truncus Arteriosus? Yeah, we just talked about it, right? We said that this forms the ascending aorta. It forms the pulmonary trunk. Now, how does this happen? We have neural crest cell migration from the hindbrain. Okay, and you might be saying, okay, Dr. R, do I really have to know all this stuff? And like I said, there are certain things in terms of the mechanisms that I think you should know. Okay, I think mechanisms are very high yield, and this is an example of that. You have to know this mechanism because there's two major diseases or pathologies that stem from it. Okay, and so I would know that there's neural crest cells involved in this process. They migrate to form an aorticopulmonary septum. Okay, and essentially this septum is helping to divide the two structures that are in the name, the aorta and pulmonary trunk. Specifically, the aorticopulmonary septum is going to divide the aorta and the pulmonary artery. Okay, so they're separated by the septum. So that's the first thing, right? They're separated by the aorticopulmonary septum, and they have to undergo a spiral formation so that the aorta and the pulmonary trunk get to the right location. Now remember, physiologically, I have my right ventricle, and that's going to pump deoxygenated blood through the pulmonary artery to the lungs. So just remember, physiologically, and we're going to do this very simple here, I have my right ventricle, it's got deoxygenated blood, it's going to send blood to the pulmonary artery. And eventually, that blood is going to go to the lungs. Okay, and at the lungs, we're going to get oxygen coming in, and that blood is going to leave through the pulmonary vein, and that blood is going to go eventually to the left atrium, and eventually to the left ventricle, and eventually through the aorta. Okay, so that's the concept, just very simple. Now, the idea here is if I have this spiral formation, I can get the pulmonary artery in the right spot, I can get the aorta in the right spot. If I don't have spiral formation, something bad is going to happen, right? And so these two pathologies down here are describing that very process. So the first one is the persistent Truncus Arteriosus. So it's like the name says. The original structure has never been partitioned, or it's an incomplete partition between the aorta and the pulmonary artery. So instead of having two different structures, I just have one big structure that's taking all of the blood. So the blood from the right ventricle as well as the blood from the left ventricle are both going in to this single structure that is the aorta and the pulmonary artery. Okay, so you can see that here. The aorta and pulmonary artery are getting the blood that's oxygenated as well as deoxygenated. Okay, so there's a mixing of deoxygenated blood because my partition isn't there, right? So I have an incomplete formation of the aorticopulmonary septum. What is a classic association with this? That's DeGeorge syndrome. Now, you might say, okay, hold it right there, Dr. R. I thought tetralogy of Fallot was the classic association for DeGeorge syndrome. And I would say, you know what? You're probably right if that's what you were thinking. Because my number one association in terms of cyanotic congenital heart defects with DeGeorge syndrome would be tetralogy of Fallot. That would be number one. However, if you really want to, start to dig a little deeper, dig your heels in the dirt a little bit, then I would say the second most high yield association would be persistent Truncus Arteriosus. Okay, so that's something to remember. It's sometimes asked about with DeGeorge syndrome. What are some features of DeGeorge syndrome? Okay, the big one, hypocalcemia. So remember, in a board question, sometimes they're not going to tell you that the patient has hypocalcemia, so you have to know, some of the things that you might be looking for, like tetany, for example, Chvostek sign, Trousseau sign, right? Those are all very classic. Facial deformities would be also very classic. A prominent bridge of the nose or micrognathia, hypoplastic nose deformities are also associated with it. So just facial deformities, cleft lip, cleft palate, those are all very classic for DeGeorge syndrome. So there is a classic association there as well. All right, so again, but the big thing, going back, kind of bringing it all together, the key is mechanisms, right? That's what you really want to know. Now, when we go on to talk about transposition of great vessels, what are we talking about? In this case, it's not the partitioning that's the problem. It's the spiral formation. I'm not getting the spiral formation, and because we're not spiraling, things are not in the right place. I have a partition between the two structures, but they're not in the right place. And so you can see this blood that's going from the right ventricle, it's going out through the aorta. Okay, so that's a problem because now I have deoxygenated blood coming in and it's all getting pumped right back out before it can get oxygenated. So what's happening here is we have two parallel circuits because the aorta is attached to the right ventricle, and therefore the left ventricle is attached to the pulmonary artery. And so we have two, like I said, parallel circuits. So let's see. So we have one circuit here, and then we're going to have a oxygenated circuit over here. And so this is a major problem. So neonates that have this happening, they're consistently getting deoxygenated blood. And so the idea here is, I mean, if you're consistently getting deoxygenated blood, this is going to be incompatible with life. Okay. Now you might be saying, okay, well, I still get board questions about, neonates that are 2 or 3 years old that have transposition. So, how are they surviving? Or in real life, how could someone survive with transposition? And the idea here is you need to have shunts that are going to get this blood from one location to another. For example, if I had an atrial shunt here, I can get this left atrial blood that's oxygenated into the right atrium, and that can get pumped out through the aorta. If I had a patent ductus arteriosus, it's the same concept. This oxygenated blood can get pumped out to the aorta. You need some kind of shunt so that this oxygenated blood can get into this circulation. Okay, so that's how these patients can survive. And so you can imagine if you have a newborn that has transposition of the great vessels, you want to do something to keep a channel open so that oxygenated blood can get into the deoxygenated circuit. And how would you do that? Well, remember that the patent, let me erase some of this, the ductus arteriosus usually closes between the first 3 days of life. Now, if I can keep that ductus arteriosus patent, or if I can keep it open, these patients can still get oxygenation into this deoxygenated circuit. Okay, so I can give them certain medications, like prostaglandins, for example, to keep that open. And we'll talk more about that in a future video. And this is very classically associated with mothers that either have diabetes or gestational diabetes.